Welcome back. We continue our discussion on management of hypertension in the elderly. We will now talk about diagnosis of hypertension and its classification. Previous guidelines define hypertension and recommends the initiation of antihypertensive treatment when the blood pressure exceeds 140 over 90 millimeters mercury. In those with diabetes, kidney disease, or cardiovascular disease, antihypertensive treatment is recommended if blood pressure exceeds 130 over 85 millimeters mercury. In 2017, the American College of Cardiology / American Heart Association Task Force on Clinical Practice Guideline, also known as ACC-AHA, redefined hypertension in adults as systolic blood pressure greater than or equal to 130 millimeters mercury and or diastolic blood pressure greater than or equal to 80 millimeters mercury. This change was based on findings from a number of large-scale prospective observational studies that reported significant increases in the risk of cardiovascular disease with increasing blood pressure even from levels as low as systolic blood pressure equal to 115 millimeters mercury, as well as the results of randomized clinical trials including the SPRINT trial, which is discussed further in later sections, that shows that intensive blood pressure lowering to a target of systolic blood pressure less than 120 millimeters mercury reduces cardiovascular disease and all-cause mortality to an even greater extent than does standard blood pressure lowering with a target of systolic blood pressure less than or equal to 140 millimeters mercury. Hypertension in the elderly patient represents a management dilemma to cardiovascular specialists and other practitioners alike. Traditionally, it was the general medical opinion not to decrease blood pressure values similarly to other younger patients. This was in order to avoid possible ischemic events and poor oxygenation of the organs, especially the brain, the heart, and the kidneys. Treating hypertension in the elderly was somewhat controversial until significant cardiovascular benefits were seen in studies including the UK Prospective Diabetes Study (UKPDS), 2. The Systolic Hypertension in the Elderly Program or SHEP, 3. The Systolic Hypertension in China Trial or CIS-China, 4. The Systolic Hypertension in Europe Trial or CIS-EUR, 5. The Stroke Prevention Trial in Sickle Cell Anemia or STOP, and 6. The Hypertension in the Very Elderly Trial or HIVET. The latter study was in patients older than 80 years of age. And lastly, the Systolic Blood Pressure Intervention Trial or SPRINT, which is the most recent study that forms the basis for the ACC-AHA 2017 guideline on hypertension. It has also become apparent that treatment may be subtly beneficial in reducing the incidence of dementia compared to placebo. However, all of these trials prior to SPRINT included patients with baseline mean systolic pressure of 160 millimeters mercury or more, making it more difficult to determine target blood pressures and anticipate benefits when an elderly patient presents with a systolic blood pressure in the 140 to 159 millimeters mercury range. However, the SPRINT trial shows cardiovascular benefits in lowering blood pressure below 130 over 80 even for elderly patients. Let's look at the current classification of hypertension according to JNC7 or 7th Joint National Committee. The JNC8 did not revise the classification. Now let's look at the table. Normal blood pressure is defined as systolic blood pressure of less than or equal to 120 millimeters mercury and diastolic blood pressure of less than or equal to 80 millimeters mercury. Now, prehypertension is defined as having systolic blood pressure between 120 to 139 millimeters mercury, or diastolic blood pressure between 80 to 89 millimeters mercury. Stage 1 hypertension is defined as having between 140 to 159 millimeters mercury, or diastolic blood pressure between 90 to 99 millimeters mercury. Stage 2 hypertension is defined as having systolic blood pressure greater than or equal to 160 millimeters mercury, or diastolic blood pressure greater than or equal to 100 millimeters mercury. The upper limit of normal for systolic blood pressure is considered to be 140 millimeters mercury at all ages. Checking blood pressure in both arms to assess for subclavian stenosis from atherosclerotic vascular disease is imperative, and using the highest value as the real blood pressure is a standard of care. 3 different pressure measurements taken on more than 2 office visits is sufficient, can reliably predict natural variations in blood pressure. Alternatively, checking blood pressure at home can be done with a clinic calibrated arm cuff, though errors in measurements and reproducibility can confound the clinical picture. Let's look at the classification of hypertension according to the American College of Cardiology and American Heart Association's 2017 recommendation. The main difference is the elimination of prehypertension from the classification, and instead categorizing patients as either having elevated systolic blood pressure between 120 to 129 and diastolic blood pressure of less than 80, or stage 1 hypertension with systolic blood pressure between 130 to 139 or diastolic blood pressure between 80 to 89. While previous guidelines classified 140 over 90 millimeters mercury as stage 1 hypertension, this level is now classified as stage 2 hypertension. These categories should not be based on blood pressure reading at a single point in time, but rather should be confirmed by 2 or more readings, getting the average, made on at least 2 separate occasions. Individuals are classified according to their highest systolic or diastolic blood pressure category. Out-of-office blood pressure readings, like in the home or ambulatory blood pressure monitoring, should also be obtained for comparison with office blood pressure readings. Accurate blood pressure measurements in office and home settings is required to minimize errors when diagnosing hypertension, monitoring blood pressure longitudinally, and making therapeutic decisions about changing the intensity of drug therapy. The guideline provides 7 strategies to ensure accurate readings. 1. No conversation. 2. An empty bladder. 3. Use correct cuff size. 4. Place blood pressure cuff on bare arms. 5. Support arm at the heart level. 6. Keep legs uncrossed. And lastly, support back and feet. This ends our discussion on defining and understanding hypertension. See you next time when we discuss the various special forms of hypertension.